Okay, so yes, we'll have this functional interlude. Thank you very much, Eduardo, and pleasure to be here to talk about some of our experience in microperimetry for AMD, and in particular, some of the work that we've been able to do more recently with the new advanced microperimetry device. I especially want to acknowledge my clinical research fellows, Amir Hossein Hariri and Tudor Tepelis, who really did all the hard work to collect the data that I'm going to present. So in terms of this concept of microperimetry in AMD, I think this really is an exploding field. There's been more than 50 papers in the last 5 years on this concept, so it's really a hot topic and worth discussing. And when we think about why is it such a hot topic, why is there such a great interest, it's because we recognize that visual acuity, which of course is the primary outcome for most of our trials in retina, is really grossly inadequate in the setting of geographic atrophy. And we learned that sort of firsthand. This was, and I'm going to step back for a moment, back to early microperimetry, and this is some of the studies we did with the MP-1. But this was a drug many of you probably don't remember anymore. This was a topical therapy, the Thera product that was being evaluated at NEI. And we were involved as the reading center for this, and the primary outcome was visual acuity. And we learned sort of from this study that that's really not a good choice, in part because here you can see that the black is the study eye, the white is the fellow eye. And you can see the fellow eye got worse. The study eye looked like maybe it got better, but at least didn't get worse. And it was statistically significant. It looked like, wow, this treatment works. Isn't that great? But it turned out that the autofluorescence grew just the same. In the study eye, the fellow eye in this case. And in fact, when we did look at it, I think it really highlights the danger of relying on visual acuity for this disease, especially with small sample sizes. But it was nice and more reassuring to see that when we look at the microperimetric sensitivity, that much better reflected the disease progression. You saw that showed a decrease over time in both the study eye and the fellow eye, consistent with the increase in the lesion size and autofluorescence, and gave us great confidence that this treatment wasn't working, and it was time to move on. And then you can look at other microperimetric parameters, such as the number of scotomatous points. In fact, that's worth pointing out because the FDA recently has sort of weighed in that maybe that's a particular one of interest to them in looking at the registration of new therapeutics for AMD. But in any event, there's been this growing concept, of course, that there's a greater sensitivity for microperimetric measures compared to visual acuity. Fred Chen published this nice paper, also kind of similar to what we found in the Thera trial, where he had eyes which basically had stable vision. You can see here across the course of the study, whereas the atrophic lesion continued to increase in size over the course of the study. And that was much better reflected in the microperimetric sensitivity, where you saw a decrease in the sensitivity over time. Again, emphasizing the fact that if you want to measure function in the setting of geographic atrophy, microperimetry is really the way to do it. And of course, people have suggested other visual function parameters for looking at GA patients. Low luminance visual acuity has gotten a lot of play and a lot of interest. But again, in this nice study from Robin Geimer's group, they again found a greater sensitivity for microperimetry even compared to low luminance visual acuity, particularly in patients with early AMD. And so if you're really going to be serious about using microperimetry in clinical trials and using it as an endpoint in GA registration trials, you really have to have good data on progression rates. And that's something that we have limited data on so far, because there haven't been really big series yet, but that's changing. And so as I said, there have been a couple of endpoints, whether it's mean sensitivity or the number of scotomatous points that have been suggested, and both of them seem to be quite reasonable. And the nice thing from the Thera trial is that we were able to do some work in some of the sort of the natural history arm of things, and looking at the increase in scotomatous points over time. So we have an idea of that, as well as looking at change in mean sensitivity over time. So that's led us to be able to have certain metrics, such as the mean rate of change per year, which are things that are being used. Granted, these are pretty small studies to power future trials. And of course, there's been increasing interest in looking at sensitivity, as I mentioned, in earlier phases. Robin Geimer has described an entity she called nascent GA. Some might think this is already GA. But in any event, in these patients, she was able to demonstrate that there is reduced sensitivity in these areas of of nascent GA. And this is just a paper that just came out earlier this year, again demonstrating superiority of microperimetry for looking at not only nascent GA, but even a little bit earlier in intermediate AMD patients. These patients actually had good or normal visual acuity, but yet had evidence of significant sensitivity loss, which I think information like this is very helpful because we get these patients coming in, they have a lot of complaints, and you're oftentimes at a loss for explaining why they're so symptomatic. And I think the microperimetric data can be quite valuable. But having said that, there are some challenges. I transition to talking about advances in microperimetry and the MP-3 device in general. There's a lot of interest in scotopic microperimetry, and one of the reasons are cases like this. This is a recent paper from Frank Holtz's group in Archives, where they looked at scotopic and mesopic microperimetry, in fact, in patients with reticular pseudodrusen, and they found that with mesopic microperimetry, what we typically do, not dark adapted, and with standard stimulus parameters, they didn't really see a lot of abnormality in the zone of reticular pseudodrusen, whereas you can see with scotopic microperimetry with the MP1S, they were able to demonstrate a reduction. And so that's been one of the challenges. People have said, well, maybe with our standard microperimetry in the mesopic range, we're not able to demonstrate the full range of functional deficits. And one wonders if you had microperimetry with a bigger dynamic range, perhaps some abnormalities could have been detected. So when I talk about the new instrument, it's nice that we have a bigger dynamic range. And again, similar in that same vein, this is another recent paper looking at retinal sensitivity in very early macular degeneration, again with scotopic microperimetry. And again, the point is if you use mesopic microperimetry, these patients very early on, this is just sort of AREDS 2 level disease, there was really no difference, whereas with scotopic you couldn't do that. Again, emphasizing that earlier detection would be valuable, especially since many companies are plotting the possibility of early intervention trials, and how are you going to actually measure that you're having some benefit. So in any event, the scotopic microperimetry is great. I think it's a great concept. It's a great research tool. But we've been very interested in, well, what tools can we actually use in clinical practice? Because that's really what's meaningful to all of us in care of our patients. And scotopic microperimetry is a challenge because it really, you obviously have to dark adapt the patient, and the tests are fairly long as a result, and requires a skilled operator. And so what we've been looking forward to for some time is advances in microperimetry, and again, we're expecting that this would happen, but the next generation of microperimetry, I think, is really required to allow us to actually take microperimetry from being a research tool to something that's really broadly applicable in our management of patients with AMD as well as other retinal diseases. And so naturally, we were pretty excited to get a chance to work with the latest generation of microperimetry technology in the MP-3 device, and I thought I'd share some of our experience just to highlight some of the advantages of the new technology. One of the challenges of microperimetry also is that it's not only dependent, obviously, on the patient, it's still a subjective test, but there's also some operator variance. I mean, more skilled operators can do a better job, and the new device has certainly eliminated some of the operator variability because you set the patient down and it can automatically track and align the patient, so that can potentially be of benefit in terms of reliability and make things perhaps a little bit easier for the patient. The thing that we've enjoyed the most, though, is the larger dynamic range. The fact that before we're going 0 to 20 dB, now we have 0 to 34 dB, and there's benefit on both the low end and the high end. So if you have this kind of range, perhaps there's an opportunity to identify defects even in patients with earlier stage AMD, which, as I said, would be pretty valuable for earlier intervention studies. And there's also a higher maximum tap-out range. So if you really want to probe the bed of atrophy and try to find areas of preserved function, there may be an opportunity to do that if you're able to use a brighter stimulus. Another advantage is that it comes with a higher resolution fundus image, and I'll show you we've been using that to good effect for doing a lot of the structure-function correlation analyses that we're interested in. So let me share with you some of the work that we've been doing with MP-3 microperimetry for what we think are customized assessments of geographic atrophy. So one of the nice things with the new touchscreen sort of interface is it's very easy to create new patterns, and that's been a big focus for us, is to customize patterns so you can easily add or remove points and adjust their starting sensitivity level. These are all tricks and techniques that we use to speed the testing, because again, our whole focus in our group has been how can we simplify the test, what can we do so that we can actually do this in a broader swath of of patients coming into the clinic. Another thing, as I said, since we've been particularly interested in GA, is that we've been focusing on the so-called junctional zone. So we now know that, this is from the RS-3000 en-face OCT image at the choroidal level, but we know that OCT is a great tool for identifying atrophy, and we can detect the areas of atrophy as areas of hypertransmission on the en-face image coming from the choroidal slab. But looking at the areas around the GA lesion are actually sort of the hotbed, if you will, for future therapeutics. And so what we've done is, it's relatively easy to take the en-face OCT data, register it with the MP-3 fundus image, and then we've designed custom patterns. This is just sort of showing the area of GA and then the surrounding area. And we've been designing some custom patterns to try to better understand the so-called junctional zone. And I'll show you more information on that. Another advantage of being able to do customized patterns is if you have really large lesions, like this patient has a gigantic GA lesion, I mean, having a standard pattern where you're doing a ton of spots in the center makes no sense, right? I mean, again, it depends. If you're interested in probing areas of preserved function, by the way, with the higher dynamic range, there's some areas where, they were still seen. Granted, it was a value of 0, but they could still see that, which we were missing before. That's how we've kind of benefited from the higher dynamic range. But that's sort of besides the point. Really what I'll emphasize here is we were able to increase our spot density in the surrounding areas, which we really want to study, and minimize the testing or the waste of time for the patient looking centrally. And that's a real advantage with the new device in being able to do that relatively quickly. So I want to make a point that one of the things that this case nicely illustrates is if you look at the points in the so-called junctional zone, you can see there's some areas of the lesion around the lesion which seem to be quite reduced and others that are relatively preserved. And that's something that's very interesting because the junctional zone isn't always homogeneous around these GA lesions. And again, we've taken advantage of some of the en-face tools in the OCT instrument to be able to look at the junctional zone, and I'll get into more detail on this in just a moment. So again, this is that en-face OCT image from the RS-3000 in yet another case, and again, you can see how beautifully well you can see the GA lesion at the choroidal level. So we were very interested in probing the junctional zone. So we sort of arbitrarily, again, there's no magic to this. We just had to come up with a value. So we said the junctional zone is about 500 microns from the border of the GA lesion, and we studied different elements of the junctional zone, those that were sort of still in the bed of atrophy, ones that were just outside, and ones towards the edge of the junctional zone, and then ones beyond, to look to see how does the sensitivity vary in the study across these different zones. Again, I want to be clear, the choice of 500 microns is purely arbitrary. So this is, again, the strategy we use where we would take the atrophy as determined by the OCT, in this case, from the en-face slab, and then we'd create this 500 micron zone around, even centrally as well, around the GA lesion for our studies. And this is just a lot of data. Just don't worry about the busy table. The bottom line, what I want to point out is, and these are the 4 zones here, what you can see is that, at that right at the bed of atrophy, if you will, there's a pretty steep drop-off in terms of sensitivity. And then, as you get further away from that, the sensitivity on the population overall didn't change that much. So again, to sort of reiterate, in the zone 1, right at the edge of the transition, there was significantly reduced sensitivity compared to further away. And further away, there really wasn't much of a change. And so this suggests a fairly sharp functional transition with apparently reduced sensitivity. I mean, this is below the numbers we were seeing in normals at that age. So it suggests a fairly sharp functional transition with reduced sensitivity in a fairly broad area, apparently, beyond the GA, at least in the cohort overall. But what's more interesting to me, I think that's fine, but that's been shown by others. That's not so exciting. To me, what's more interesting is the variability that the patients have. So we saw, I'm very interested in this kind of structure-function correlation, and so we would do these en-face labs. So this is a nice en-face lab from the RS-3000 at the level of the photoreceptors, okay? And you can see, you can see the atrophy and the loss of the photoreceptors here. But notice that around the bed of atrophy, it doesn't look too good either. It's kind of got this ring of darkening, and that seems to correspond. You can see there's a lot of yellow points around there. There seems to be reduced function, reduced sensitivity corresponding to that change. Now, again, there are other GA lesions like this one where there really was nothing beyond the edge of the GA lesion in terms of the photoreceptors. And you can see here the sensitivity is relatively better preserved. And so that was very interesting to us because, you might say, well, why was it interesting? Why do you care about that? Well, we care about that because, this is something that my friend Phil Rosenfeld, Vascular Palmer, had also illustrated. And he said that if you look at the outer segment level on non-fuzz OCT, you can see these areas of darkening, and they seem to predict where the GA lesion was going to grow to. So if you think about you're doing studies and trials and you're trying to understand, like, is this patient at high risk for progressing or what's going to happen, this kind of information could be quite valuable. And the upshot is, again, so this is the regions of photoreceptor disruption predicted future areas of atrophy. Phil called this dead retina walking in honor of the Dead Man Walking movie. But the implication, especially with the sensitivity correlation, is that regions of decreased sensitivity around the GA lesions may predict lesion growth and functional loss. So that'd be something be interesting to study in prospective studies. Now, we've also been interested in studying this in the context of early and intermediate AMD because we really wanted to test out whether we could demonstrate functional abnormalities with taking advantage of the larger dynamic range of the new instrument. So we recruited these kinds of patients. For these patients, since we didn't really have a lesion to focus on, we used a standardized pattern that you can see here, 33 points, Goldman 3 stimulus, and we used the full dynamic range with a 4-tooth threshold. And then we also quantified, using the tools available for automatic quantification, the OCT device, different elements, the outer nuclear layer, in particular the photoreceptor outer segment complex. So this is just a segmentation from the RS-3000 for this case. And in any event, we were able to compute these kinds of thickness and volume maps for these structures of interest, which was kind of cool. And then we were able to, again, sorry for the busy tables. This is just sort of showing the mean statistics on the cohort. But the bottom line is that it was interesting that the mesopic sensitivity was significantly reduced in these patients compared with age-matched normals, and the correlation that was observed between, we found this correlation between the foveal central subfield sensitivity and the outer segment volume, as you can see here. And so we're excited about the prospect. Again, this is something we obviously want to look at in larger cohorts, that the larger dynamic range of the new device may allow us to actually interrogate functional deficits in earlier disease states, which would be pretty exciting. So, in any event, I've given you a little flavor for some of the things that again, my area of interest is really AMD, so that's why I'm showing you old data from that. But I think microperimetry provides valuable information at various stages of AMD. I think it can provide us new insights into pathogenesis and prognosis and progression, especially those changes around the border of the GA lesions. And I do think that the increased automation speed and dynamic range of the new perimetry technology has an opportunity to facilitate its broad use in clinical trials, clinical research, and in clinical practice. So really, we're trying to see how can we simplify things further so we can start to do this on almost every patient that comes in. Thank you.